My name is Rainah Fitzgerald. I'm one of the client concierge at CandorPath. On behalf of our entire team, even though it's just John and I today, we just want to say thanks so much for taking the time to do this again on the first day of open enrollment. And as we get into the depths of Medicare planning, hopefully we can answer all of your essential questions. And speaking of questions, as we go through today's session, feel free to drop any of your inquiries in the Q&A box at the bottom of your screen. Or just as our friends used here, you can also use the chat box that can either be anonymous or to us or to the group itself. So feel free to use either of those features. We'll be monitoring it. And if we don't have time to address all questions live, or if it's more of a personal question, we will definitely make sure to follow up with you in the next 24 to 48 hours personally. So if you haven't had the pleasure of meeting him yet, John Kennedy, my colleague and my friend, he is a certified financial planner. He'll be our host today with over 15 years of experience. He has a deep understanding of the specialized area of financial planning. So with that, John, let's go ahead and jump right into it.
Thanks, Raina. I also want to give a special thanks to Joyce Kennedy and Oasis and Lake Nona for joining us today. This is our 8th year doing this presentation with the Oasis crew and our clients. And originally, we would come visit you guys in Lake Nona, but in more recent years, we've moved it to Zoom so all of our clients could join as well as Oasis members. So thank you for spending time with us today and chatting about Medicare. First, I want to talk about, well, a couple things. What is this presentation and what is not this presentation? So it is robust. It is a deep dive. So please take notes. Know that this is being recorded. We can share the playback with you after, but it's an open and honest assessment of all things Medicare and how to best ensure you're maximizing it relative to your finances and your healthcare needs. What isn't this presentation? We have no interest in selling you or convincing you of a product or some type of Medicare program. For most of you on this call, I'm one of your CFPs here at CandorPath. We're a team of advisors because we understand that we can't know all things individually. And so one of my areas of advisory support is healthcare planning, Medicare, Social Security, really all the things that involve that transition into retirement. Now, each year, Rain and I try to reinvent this conversation to keep it fresh and relevant and topical. So for this year, our hope is to specifically address the goals that you see here on your screen. They say that Medicare can cost a healthy couple turning 65 upwards of $500,000 over the course of their retirement lifetime. So that, from an actuarial standpoint, that 30 years between 65 to 95. So let's learn what to do by first learning what not to do. We want to help you avoid the 3 biggest mistakes that we see Medicare enrollees make. We want to identify the top changes we see coming into 2026. And there's a lot of them. They're calling it the great reset of Medicare. I think that's kind of like aggressive marketing mumbo jumbo, if you ask me, but there is definitely changes coming and we need to talk about that. And then also, as Raina mentioned, ask questions along the way. We'll monitor, try to get them in real time or save them for the end if we have time. So for those of you that have heard me talk about Medicare before, what I'm about to say is not a surprise to you. It all boils down to 2 choices when it comes to your Medicare. Yes, we get all this product information on the news, and commercials on the news and stuff in the mail. And there are subsequent choices that you do need to make amongst product companies. But at the top of this decision tree, it boils down to 2 different options, and that's Medicare Advantage or Medicare Supplement. So we want to talk about what those key differences are today. We also want to address IRMAA. Not getting this right can cost you thousands per year, and in some cases can be avoidable. And for those of you that haven't heard of this term before, it stands for Income Related Monthly Adjustment Amount. And we'll talk about this in a little bit. And then last but not least, missing important enrollment dates. That has an irrevocable impact on your coverage options, and we can't afford for that to happen. So let's talk for a moment about what is Medicare. This was created by the government back in 1965 as a means for retirees to have health insurance once they left the workforce. And it comes in 2 parts. There's Part A and Part B, which we'll unpack here in the next couple of slides. But Part A and Part B, the combination of those 2 are what's known as original Medicare. Now, for those of you that are not 65 yet, that are turning 65 soon, or those that might remember on your employer plan, we were used to family coverage options. That's not the case with Medicare. It is a per person individual benefit. And for most families, you do not have a premium for Part A. And, I listen in preparation for stuff like this. Rain and I listen to like other podcasts and publications about how folks are talking about Medicare. And I always hear them say that additional health insurance may be required. And I'm going to go out on a limb and say that it must be required because aside from taxes, healthcare will be one of the biggest expenses that you incur in retirement. So we have got to plan for it. Now, I talked about what is Medicare. Let's talk about what is not Medicare. We hear things like dental and vision being covered. Oftentimes in those situations, what you're actually seeing is a Medicare Advantage product. And we're going to talk about this too, but they're add-ons to a plan. And even those are being faced with reductions in benefits. But Medicare as a whole, Part A and Part B, does not cover dental. It does not cover vision. It is not, and you'll see here why in a moment, a suitable replacement for long-term care insurance. And of course, it doesn't cover things like optional procedures. So for those of you that are taking notes, what I'd like for you to do is write Part A, and then right next to that, write hospital insurance. And next to that, write $0 per month. As long as you have paid into Medicare for at least for Medicare and Social Security tax, as long as you've paid this tax for at least 40 quarters or 10 years, which most of us have that are working, or your spouse has, your Part A premium will be $0 per month. Now, it has a deductible associated with it. That deductible is $1,700 or projected to be a little more than $1,700 going into next year. And the projected numbers for next year kind of look like this. So, once you're in the hospital after you've paid your 1,700, you'll have a daily, for the first 60 days, a $0 per day copay. And then days 61 through 90, it'll be $419 per day. And then after day 90, something important happens. It's called your lifetime reserve days. And you only get 60 of them. So if you use them all up that first time in the hospital, it's $838 per day. But once they're used up, you really only have coverage on Part A on days 1 through 90. Rainah, do you mind maybe sharing, because I've got something kind of important underlined here, which is per benefit period. Do you mind sharing with our listeners what that means?
Yeah, for sure. Per benefit period starts the day that you enter a hospital or an inpatient facility. And it actually ends the day that you have had 60 consecutive days without any care. So because of this structure, there actually could be multiple benefit periods per year.
Yeah, and that's a really big deal to know. And it kind of shows, I think most of us are used to annual deductibles. So A, it's not that in this situation, but it also shows the deficiency in coverage of Part A of just how expensive it could be if you have extended hospital stays. Now, again, if we're taking notes, below Part A, I'd like you to write Part B, and this is your doctor's insurance. So write Part B, doctor's insurance. And then next to that, you could write 185, but actually update number one, as I promised, we're going to provide the updates throughout this conversation. Update number one is that your Part B premiums are projected to go up to 206.50 per month. Now, Part B is going to be, again, as I mentioned, doctor's insurance. So for your physician visits, primary specialist visits, outpatient procedures, home health visits. And though it's going up in premium, the deductible is going up as well. It's projected to go up to 288. But I'd actually say that in comparison, for folks that are on employer plans or even ACA plans, a deductible of only $288, and this one's per year, by the way. This is January 1 to December 31st. A deductible of 288 looks pretty amazing when we compare it to some of these ACA plans that we see $6,000 to $9,000 deductibles.
Yeah, John, just pause right here really quick. This is great. Does this represent the cost for everyone? I know that we've seen a lot of client situations where they may be paying more than the actual 200, this 206 amount. So I might be getting ahead of myself, but can you better help explain how IRMAA gets folded into this in this case?
Yeah, that's perfect because that's actually, even though we're kind of going out of order, it makes sense in the flow of our conversation. That's actually one of the the biggest mistakes we see folks make is not planning properly for IRMAA. So again, I mentioned this at the beginning, but it stands for income related monthly adjustment amount. And I think that this visual here, this is the 2025 number. So obviously these numbers are a little different. But this visual here depicts how this works. So the first thing I want to call to your attention is the term modified adjusted gross income that you see here and here. MAGI, modified adjusted gross income. That's your top line number. That's like before deductions and everything. That's your income, your Social Security income, your retirement distributions, maybe a salary that you take. That's the top line number that flows through on your tax return. And the second thing I want to call to your attention is at the top where it says if your filing status and modified adjusted gross income in the tax year 2023 was, like, you're probably looking at this going, oh, that's weird. Like, that must be a typo. Like, why does it say 2025 here and 2023 here? Well, there is a very important reason for that. They have a 2 year look back when it comes to fact checking you on what you say your income is. They don't just trust us to say, oh, yeah, we retired, our income is this number. They go, well, the government wants to look at the most reliable, accessible data that they have. So let's pretend you're turning 65 in February of this year of 25. You hadn't probably even filed your tax return for 2024 yet. So the most accessible thing that they had to fact check your income would have been to go back 2 years in 2023. So that's why that 2 year look back exists. Now, you might be wondering and saying to yourself, well, okay, my income was, let's say, 215,000 in 2023, which if you're a married filing jointly couple, that puts you in that first surcharge number of going from 185 to 259. But I've retired. My income's no longer that high. Is there something I can do about that? The answer to that question is, of course. Surprisingly, well, maybe not so surprisingly, Medicare and the government, like they're not specifically advertising to you like, hey, let us know if you've had this big life event change, which could look like retirement. It could look like, maybe a home move or also the loss of a spouse, some type of qualifying life event. For most folks, it's retirement. Okay. So let's say that's the situation. Well, you can scan this QR code here. It's going to take you straight to ssa.gov. It's actually going to take you straight to this form called the SSA 44 form. And you fill this out, you send it to your local Social Security office, and you wait about 30 or 45 days. And I know that sounds very skeptical to most of you listening because I was skeptical when we first did this years ago for a client. But surprisingly, they're very responsive because it's a change that they're willing to make as long as they can fact check it and go, yeah, 2 years back, we see that this is what your income was. But you're telling us you retired, you sent us your final pay stub and, a statement signed by your employer that you've since retired. So we know your income is going to be lower. Yes, we will remove that additional surcharge so that you're not paying it for let's say 2 years before, longer than you should be paying it.
Yeah, John, so what about those that fall into the higher brackets? How do they help reduce their IRMAA surcharge there?
Yeah, and I think the issue too is like the scenario that I just kind of outlined was for the folks that fall into this scenario more as like a one time or like an anomaly. Like they've retired and now their income's below this threshold, so they're fine. But there are others who are in retirement when you factor in pensions and social securities and IRA distributions and rental incomes that they're above these thresholds. So there is plenty that can be done. Many of the planning strategies do require pre-planning. So, the years leading up to age 65. For example, if you had a $2 million investable portfolio, but most of that's inside of a 401k or an IRA, as you're probably aware, any distribution you take from that retirement account is going to be taxable in the year that you take it. So if we said, well, what if we could build up some non-IRA assets or convert dollars to Roth IRAs, we can begin to build buckets of money that are available to you in a more preferred tax manner later on for this very circumstance, which can save thousands each year. It's a pretty big deal. Everything you see here on this list of strategies is something we've done before for clients. And it's part of the customized planning that Matt, Michael, Brandon, and I deploy for you as clients. Rainah and I actually decided we were going to host a webinar on this, on just these IRMAA planning strategies alone, targeting for January of next year. So if that's something you're interested in, send us a message on here. We'll make sure to get you an invite out when that information is ready.
Yeah, so just to give you a little bit of a breather here, John, I just wanted to touch on a
Get you some
recap.
water.
So far, we have a better understanding of the costs and coverages for Medicare Parts A and B, which is most commonly known as Original Medicare. And now we're going to just take a moment to go over the add-ons that work actually alongside or actually replace Original Medicare.
Yeah, yeah. So we're getting back to that number one biggest mistake that we see folks make, which is misunderstanding the key differences. By the way, Raina, we do have a question which I'm gonna save for the end because it's about somebody who dropped Part B and is looking to re-enroll. So we're gonna touch on that towards the end and hopefully answer that question well. So if you remember how I mentioned kind of in those opening slides that you've got two choices to make when it comes to your Medicare planning. I think this graphic best depicts what those look like. So you have what we've already explained, which is original Medicare Parts A and B. So we think we can all agree we kind of know what that looks like now. You've got, in this instance, what most people do is they have a standalone Part D plan, which we're going to save all the prescription drug stuff for the end, but that's what Part D is your prescription drug coverage. And then what most folks do if they elect original Medicare is they also select a Medigap plan. This is also known as a supplement plan. So those words are used interchangeably. Conversely, what we see folks do as well sometimes is Medicare Advantage, also known as Part C. Medicare Advantage replaces original Medicare Parts A and B. So you basically say, okay, we're going to go with this and we'll add on a Part D and a supplement, or we're going to go with a Medicare Advantage Part C, which most of the time also includes a Part D. It's known as a MAPD. There's so many acronyms and letters and numbers that are being thrown out. I don't think that one's important to know, but in case you see that, that's what that is. An MAPD is a Medicare Advantage with a prescription drug plan.
So, Medicare supplement, also known as Medigap, it was in that little tiny bubble where it says private companies.
Mhm.
These Medigap plans are not official Medicare plans, but instead they're actually privatized supplements to original Medicare. So, just a couple of things here. These are, again, done through private insurance companies, not the government. The costs of these supplement plans and are in addition to the Part B premium of that $206.50 that we were talking about earlier. Again, that's per month. And then there is an array of different plans that John is actually going to talk a little bit more about here in just a second.
Yeah, Raina, before we do that, do you mind talking to us about, because this is a question that we get often from clients. We've built up these HSA funds. HSAs have been around for about 22 years. So clients are retiring with money in a health savings account. What can I do with that in retirement?
Yeah, I'm glad that you brought that up. I always love this little quick tip here at the end. So even after you enroll in Medicare and stop HSA contributions, you actually are still able to withdraw funds tax-free for qualified medical expenses. So you can use your HSA to pay for some Medicare expenses, and this is a little bit of a mouthful, but that includes Medicare Part B, Part D, and then Medicare Advantage plan premiums, deductibles, co-pays, and co-insurance.
Yeah. And so the only thing that you can't use it for is your Medigap or supplement insurance premium, which frankly, I don't know why. Like, I don't know why like everything else was included and that was specifically excluded. But what I want folks to hear in this message is not to be discouraged. In fact, if we're pre 65, for those of you that are on this call that are still adding to an HSA, keep doing it because we want those dollars in a tax diversified bucket. And trust me when I say there are going to be medical expenses that we can figure out how to, justify spending so that those monies come out tax free. That's the big distinction with an HSA. You put it in and get a tax deduction, you pull it out tax free if it's used for qualifying medical expense. So as you said, there's the supplement chart that I want to share. There's an array of different supplement options. Actually, they back in the 90s, they decided to do these name-based plans, which is incredibly frustrating for anybody that's, I can imagine like in the early 90s when they came up with this and we're like, hey, okay, so great, you have Part A and Part B. Or you could do a Part C and you're also going to have a Part D for your prescription. And then supplement companies come out and they go, and we're going to have Plan A and Plan B and Plan C and Plan D. How confusing is that? And so what we've seen as years have gone by is a lot of these different plans are somewhat irrelevant and some have been done away with completely. And so just for sake of ease, let's kind of clear out some of the ones that we know have been done away. So C and F no longer exist for new enrollees. Now, I know because I can see the list of names on here today. There are clients on here that I helped years ago set up a Plan F. So as you know on this, and I know as well, you're grandfathered in. If you had a Plan F plan pre-2020, you're grandfathered in. You're fine. You could stay on that if you want to. For the folks that are enrolling to after 2020 or today and going forward, when it comes to your supplement plan, what we often see people elect is either Plan G or Plan N. Now, by no means is in this presentation today me making a recommendation on what you should do. I'm kind of giving you an idea of what the most commonly applied for Medigap plans actually are. And let's maybe kind of talk about why that is. So let's look at Plan G for a moment. If we kind of go line by line here, you can see, so we've got Part A, coinsurance, Part B, coinsurance and copayment, blood work, Part A, hospice care, skilled nursing facility, Part A, deductible, Part B, excess charge, and so on. And every single time there's a dot there, that means it's 100% covered. The only thing that's actually different between what was formerly known as the Cadillac plan, which was Plan F, and the now Cadillac plan, which is Plan G, is this Part B deductible. And if we rewind to the conversation 5 or 10 minutes ago, we explained that that's 200 and I think it was $288 per year going forward next year. And so not a huge downfall not to have that. And we see a lot of people elect the supplement Plan G. And maybe for cost savings, we'll see folks elect Plan N. What's the biggest differentiator between G and N? Well, you can notice that Part B deductible is also not covered. You'll notice up here it says copays for coinsurance. This looks like anywhere from $20 to $50 for, primary versus specialist visits. And then this thing called Part B excess charge. Now, early on in my career when I was learning about this, it was a big deal. At one point, this was kind of a big deal, but I've learned in practice and in reality that this rarely happens. This is where a Medicare participating provider decides not to cover something at the Medicare contracted rate. So like, you have a knee surgery and it should have cost $4,500. That's what should have been billed, but they actually wanted to bill $6,500. So that $2,000 variance. Well, rarely does this actually happen. And it's something important to know is that they actually legally can't charge more than 15% of the contracted rate anyway. So in my example that I just gave, a $4,500 procedure would be capped at $5,100 if that medical provider decided that they didn't agree with those contracted rates. We're finding that to be a very rare occurrence, which makes Plan N attractive for folks that want to save on premium. And that kind of leads me to my next point. Update number 2 is we're projecting to see rate increases of 8 to 12% from this year to next year on all supplement plans. It could be more, it could be less, depending on the company or the plan that you're with. And I will tell you, in my experience, insurance never goes down and never seems to stay the same. It does always go up. It's just a matter of how much is it going to go up year over year. And there's a reason for these rate increases. The first one is inflation. We've all heard that word. I heard Matt and Michael talk about it at the quarterly update last week that we did. Inflation's a big deal. But I think what's maybe a little more surprising for folks, and one of the reasons that premiums are going up, is that people have returned to getting proper care. During COVID, it was very common that people were delaying services and delaying care, and now insurers are seeing an increase in claim. The third thing that might also be surprising, and this is a little bit of a newer trend in the last few years, is that folks are waiting until they go on to Medicare for a major procedure. So like I had a client do this recently, 63 years old. He needs a knee replacement surgery. And he's like, John, I can tough it out. I'll grit it out for 2 years so that when I turn 65, I can have this done and I can have this covered for me. So, one of the proactive conversations I think in this discussion that we can talk about one-on-one after this with the folks that are listening is if there's situations where we go, hey, maybe we do need to try to save some money, what should we be considering? I'll give you some kind of round numbers. Folks that might be switching from F to G, which by the way, I'm not saying that you should do this. I'm not saying that we need to do this, but what I'm seeing is that folks that do switch might save $30 to $40 per month. Folks that switch from G to N might save another $30 to $40 per month. So those are kind of the cost savings going from F to G to N. And if we were trying to, go back to that initial graph, because I like this to kind of hold us accountable as we're talking through this stuff. with the option of going with original Medicare and a supplement plan, this is kind of trying to formulate what that expected cost is going to be per person. Remember, these are individual benefits, not family benefits. So we've got the monthly premium for Part B. This is the estimated Part D on average in America for next year, but we have clients that are paying $0 per month for Part D, which we'll save towards the end. And then Plan G can be anywhere from $180 to $220 a month, kind of depends on a number of different factors there. So, as I continue the talk track with supplement before we switch to Advantage, a couple things I want you to know. This is at your initial or special enrollment window, guarantee issue. They cannot rate you, they cannot decline you. It does not matter if you had cancer, if you have cancer, have had cancer, have a heart condition, have diabetes, whatever the qualifying event that any other insurance company for like life insurance or other health insurance needs might decline you for. They cannot do that at your initial or special enrollment window. Now, after that point, so if you go on a different kind of plan and you decide to switch to supplement 3 years in, that's different. And we'll talk about that here in a little bit. But at initial enrollment, it's guarantee issue, which is a really big deal. I think the reason other folks select supplement plans is the freedom of choice when it comes to your providers. There's no networks. As long as your doctor accepts Medicare, which 98.5% of non-pediatric doctors do, as long as they accept Medicare, they have to accept your supplement plan. It doesn't matter if it's with Aetna or Cigna or United or it doesn't matter. It doesn't matter who it's with. They accept that supplement plan if they accept Medicare. And so for folks that are listening to this, like, ease of use is a big deal. It's just really straightforward. And I think some clients on this call can attest to that the ease of use. You go to the doctor, you go to the hospital, you bring your Medicare card and your supplement card, and that's it. You call it a day. Rainah, how am I sounding? Am I coming through okay? Or am I cutting in and out?
You cut out there just for a little bit, but I think we're back. We're rolling.
Let me know if that happens again, if I have internet issues, and maybe just I'll repeat something if I need to, as if it gets too choppy. So
Yeah.
switching gears and continue to ask questions. I see another question come in here, which we'll try to get to towards the end from our very own Michael Scott. Is that our Michael Scott, or do we have another Michael Scott on here?
That is our very own.
But switching gears, feel free to ask supplement questions. I'm going to switch to Medicare Advantage Part C. And this has worked very similarly to how you've always seen and felt your health insurance work. If you're just turning 65, you're used to, all right, I've got copays when I go to the doctor. I've got a co-insurance of 70/30 or 80/20. I have a deductible and an out-of-pocket max. You're used to those type of terms. So supplement's really different because if you think back to that chart that I showed you, basically it's like, hey, if you pay your premium, these things are all covered and you don't have to worry about it. Whereas with Advantage, you're going to have deductibles and copays and co-insurance, which leads me to update number 3. So I talked about supplement prices increasing 8 to 12%. Advantage prices, the national average across the board is that they're going to increase by about 5% next year. So how am I doing, Rainah?
You're doing great.
I just needed a reason to take a breath and say hi.
Yeah.
All right. So as we kind of keep talking through Medicare Advantage, couple important things I really want you to know. It's also offered by private insurance companies, and it's effectively a replacement of Part A and Part B. So by that very nature, at minimum, they have got to cover what A and B already cover, what we talked about at the beginning of this presentation. And then they add in things like an out-of-pocket max or a deductible or a copay. So the out-of-pocket max projected for next year is $9,250. You'll see Advantage plans offer lower out-of-pocket maxes, but that's the highest number that they're allowed to offer. And the type of person that, let's say, is like a little more comfortable with a Medicare Advantage Part C is someone that wants lower premiums and maybe they're comfortable with dealing with managed care. So what do I mean by that? Managed care looks like we're dealing inside of an HMO network or a PPO network. So we have in-network doctors and out-of-network doctors. And this could be a really big deal for folks that have 5 or 6 different doctors between primary and specialists that they need to see. It might be hard to find an Advantage plan that covers all 5 or 6. So then we have to prioritize what are the ones that we absolutely must have and what are the ones that we could replace. And And so, something else I'm kind of seeing is, you notice I mentioned here HMO and then below that HMO POS. So I'm finding that going forward, it seems like there are less and less PPO plans being offered. And I guess it's because companies can't make the kind of margin that they used to. And so the HMO POS is a newer and more common plan. Now, POS doesn't stand for what you might think it stands for. POS stands for point of service. So it's really similar to a PPO plan, but it's truly an HMO network. But you have the option to go out of network as long as that provider agrees to take that plan. And as you're probably familiar with an HMO, like if you need access to a specialist, typically you need to go through a primary, and then that primary writes you a referral to get to the specialist. So again, when I say it's the type of person that's comfortable dealing with managed care, that's kind of what I mean. But with that situation comes a cost savings. So again, as I mentioned before, we like holding ourselves accountable in this to like have little checkpoints of summarizing and hopefully making sense of what we're talking about. You're probably smart enough to see, hopefully I'm smart enough to add these numbers up correctly. I hope no one fact checks me on these numbers, but you're probably smart enough to see and paint a picture of what's going on here and that there's going to be trade-offs between those two options that we have to pick from. If you literally tuned out this entire presentation up until this very slide, you could probably come to a conclusion that one's more comprehensive, whereas another one might not be, and it's going to be more of a managed care situation. So I feel like this slide's really good to kind of, at least just in one shot, compare and contrast the major, major differences between the two. So with original Medicare, Medigap, and a Part D, there's no out-of-pocket maxes. There's no network issues as long as they accept Medicare, which 98.5% of them do. There's no referrals needed, but you're going to need to, if vision and dental are a big deal for you and hearing, you're going to need to get a standalone plan for that type of situation. Whereas with Medicare Advantage, you will have an out-of-pocket max, you will have managed care and an HMO or a PPO or HMO POS, and you're going to have to work inside of a regional network. Now, one of the perks that Advantage plans do have is they'll add things like vision or dental allowance. But let's be careful about what that looks like going into next year. There's a big shift coming away from these like comprehensive coverages for things like that, and they're moving more towards preventative coverage. There's a term that they use for this when they change plans that are similar. They call it, they say that, the company's crosswalking the plan. So it's not exactly the same plan next year. They're offering a different one for you that you're enrolling in based on the one that you were on that prior year. So we want to look for things like that. Like, are they affecting or changing coverages like dental and vision? And probably equally as important is not just these very quantitative factors of what are the costs, what are the premiums, how does this plan work, but there's very qualitative components to this decision as well, right, Rainah?
Yeah, I personally love this slide. I think for us and the clients that we work with, the decisions really come down to the factors between Medigap and Medicare Advantage. So again, like we've said today, our goal is not to give you an answer for what you should do, but rather just empower you with the tools to make the right decision for yourself and really just to get a better grasp of what all this Medicare stuff even is. So, budgeting does matter here for a few different reasons. Let's talk through those. Maybe some people are on a fixed budget. Maybe some of you are comfortable with managed care versus not. Or maybe you travel often and you prefer the access to more providers. And on the other end of that spectrum, maybe you live in a community with well-established doctors that are on your HMO or PPO Medicare Advantage plan, and you don't have the same problem with managed care. Say you have a greater need for a more comprehensive plan due to cancer, diabetes, or any other ongoing conditions. And if this is you, we don't blame you for preferring Medigap. And finally, risk tolerance is certainly another factor. Some people have higher risk tolerances, and some people are naturally a little more nervous of the unknown costs that might come with Medicare Advantage. Ultimately, no wrong answer. When we work with clients, we've just learned that their financial plan really helps inform us of the best decision to make here.
Yeah, well said, Raina. And while we're on these couple of slides, I do want to mention something. So I'm going to go back one slide. Someone asked in the chat with Medicare supplement, Plan G in this specific case, is it the same with whatever company that you go with? And so the short answer to that is yes. Like Plan G is Plan G. If you remember that graph I showed of like plans A through N, if a company offers that plan, they legally have to offer the coverage for all those same things. The only differentiating factor between one Plan G to the next is the cost, the premium. That is truly the only differentiating factor between the two. So great question. And yes, it's the same with whatever company you go with. Now, what I will share is there are some companies that we see come into the marketplace of Medicare supplement, and they'll kind of come in with like really low premiums the first couple of years. And their goal is to try to kind of capture a lion's share of new enrollees that are coming in and getting on these plans, and it's attractive because the premium's lower than everybody else's. And then, the boil the frog analogy where they just kind of keep, cooking, dialing up the pressure until you're boiling. They start increasing rate, they start doing rate hikes at a pretty aggressive tone. So we want to look at a company that's going to be mindful of not, offering a really low introductory rate and then 2 years into it, you're paying 40% more than you were in that first year. And you're going, what just happened? Like I picked this plan because it was the most, it was a good cost plan. Follow-up question that I'll try to answer real quick in real time is, can you change companies every year to get a lower rate? Yes, but you have to go through underwriting even if you're just switching Medigap plans. So you'll notice here on this slide, guarantee issue at onset. So at 65 or special enrollment window, that's guarantee issue, requires underwriting afterwards. Underwriting is going to be 35 to 40 medical questions. They're going to look at your prescription drugs. They might even require a written letter from your doctor. That's not to say it's not impossible. In fact, I have clients switch from one Medigap plan to another, but underwriting is a big deal. So that's something that we do need to be mindful of. And one final note, and it says it here at the bottom, you can do that anytime during the year. You don't have to wait for open enrollment to switch from one Medigap plan to the next. So that being said, hard right turn into Part D prescription drugs. Kind of save this towards the end because it's the one that seems to have the most moving pieces. So this is where you'll see a lot of the updates coming for Medicare going into next year. But, a couple things I want to mention as we've talked about, you're kind of seeing a consistent theme. It's offered by private companies. Yeah, I'm seeing this question. Still need to go through underwriting. Yes. Yep, still need to go through underwriting if we're switching Medigap, even if it's the same. So for prescription plans, the biggest thing that I'd like to share is, well, there's a couple. You have a standalone plan, which you would have if you pick the Medigap supplement, or it would be combined with your Part C Medicare Advantage. So someone asked a question, is prescription drug coverage part of Advantage? Yes, in most cases it is. And the plan that you select will explicitly tell you that, or I can look at it for you. But it's known as an MAPD, Medicare Advantage Prescription Drug Plan. So, a couple of the things as I digress on this, this is going to be for personally administered drugs. That's important to know. So if it's professionally administered, like if you're in the hospital and they administer drugs to you at the hospital, all that's going to fall under Part A. Or if it's an outpatient procedure and they administer drugs to you, that's falling under Part B. But this is going to be for personally administered drugs that that you fill and that you take at home. Another important thing to know is the deductible is 615 this year. However, it does not apply to tier 1 and tier 2s. Those are deductible exempt. So if you have a tier 1 drug or those are considered generic drugs. Those are going to be exempt from the deductible and they're going to be relatively inexpensive, anywhere from like $0 to $5, depending on the plan. So big change going into this coming year. Actually, it was really a big change last year, was that they introduced a $2,000 out-of-pocket cap on drug coverage for the year. They've increased that to $2,100 going into next year. And I got to tell you, I have clients that take extensive chemo drugs. They take extensive medications to treat things like diabetes and what have you. It easily tops out at $5,000 per month. So this cap is very helpful for a lot of families and individuals in retirement. Something else that happened, update number 5, is there were 10 prescription drugs that between the drug companies and the government, they basically negotiated reduced rates. Eliquis is a big one that you'll see on this list. So is Xarelto. This is a huge deal for families that were affected by these prescriptions, and it's a great example of how just one prescription can influence which plan you should be on any given year. So it's called maximum fair pricing. That was the term used for the situation going into 2026. And boy, did this make drug companies unhappy. And so we saw them do several things. We saw drug companies increase other prescription prices to help offset the fact that these 10 now have negotiated set prices. And then we also saw them go, all right, well, if this is the case, we're just going to increase the cost of everyone's plan. Everyone that's on Medicare, we're just going to increase their cost. And the government came in and said, no, not so fast. We're not going to let that happen. They stepped in and they basically set a maximum allowable increase of $50 more per month. So if your plan was $35 per month, the most that a plan could increase to would have been $85 per month going into next year. So in this game of back and forth, we saw companies respond again. I feel like I'm storytelling this. I feel like this is like a dramatic story that unfolded in the last year, Rainah. And so what we're now seeing is companies are leaving the market altogether. I've already had numerous clients reach out to me saying, hey, my Cigna plan is no longer being offered in 2026. What do I do? And other plans are crosswalking your plan, that term that I mentioned before, meaning they're putting you into something similar but different. And it's up to you and to us to evaluate if that plan still makes sense for your situation. So something important I want you to know is on October 1st, you should have received this by now, but by October 1st, these companies had to send out your annual notice of change to you to let you know what the premium was going to go up to, what the coverage was going to look like. Are they leaving the market? Cigna's one of them. They're leaving the market, like I said. So be sure to take a look at that annual notice of change, and we can talk, one-on-one to make sure that you're in the right spot. And then final update. I know I just went through like 4 in like super quick fashion. Final update is payment smoothing. This happened last year. It's kind of like 0% financing. They basically said, for folks that are enrolled, and have expensive drug costs, that you could pay it in a monthly installment instead of getting hit with that copay all in one year. So pair that with the $2,000 or $2,100 cap. This might mean that a $2,000 bill in January just became $167 a month from January to December. And the big update here is that if you enrolled in that last year, you're automatically enrolled into that for 2026. You do not need to do anything. That's automatically going to continue. But it's the way that I like to think of it is it's 0% financing for your payments. Rainah, we went through a lot. So we've got, the final one that I want to touch on, which I think will answer a question or two that I saw come through, has to do with important enrollment dates. And there's a couple reasons that this is important. Rainah, first one I'd like you to touch on, if you don't mind, is so can you talk about what the risk is if you miss your open or your special enrollment period?
Yeah, so I think there's a couple of penalties that are worth talking about here. So, Part B penalty is 10% per year permanent surcharge in addition to your premium. And Part D's penalty is 1% per month or 12% annually. But I believe the even bigger deal is actually not the increased premium cost, but it's the missing of your guaranteed enrollment period. And guarantee issue for a supplement plan would now be gone, and you'd be forced to medically qualify at this point, unfortunately.
Yeah, that to me is the bigger deal. Because if you miss a year, saying that your Part D premium is 12% higher, I mean, I guess that's a big deal, but there's some instances where people pay $0 for their Part D. So it's like not as mission critical, but what is that guarantee issue as you mentioned. And so, I think this might help address one of the first questions we got. So the question was, last December, I dropped my Medicare Part B. This was probably by mistake, and I'd like to re-enroll. And so that would be a situation where I think it would make sense to reach out to Social Security. So you can go to ssa.gov/Medicare and call that 800 number that's on there. I used to have it memorized by heart, but I don't want to say the wrong number now. Call that number and re-enroll. There will be a Part B penalty associated if you were supposed to, like if you're over 65 and you don't have an employer plan, there will be a penalty that will likely apply. I'll talk about, for this person that asked the question, if you are still employed, I'll talk about that in a second because I think that might matter. But for the rest of us that are approaching the age of 65, we have a 7-month window. So it's 3 months before your 65th birthday, the month of, and 3 months after. So you've got plenty of time to enroll and to decide and to get all this squared away. And this initial enrollment window is, again, important for that guarantee issue if we want that for a supplement plan. Notice here, I have a little tip that says if you're retired and not collecting Social Security, you must enroll in Medicare during your initial enrollment period. That's kind of a big deal. There are some folks that elect for Social Security early, which is great. If you do that, when you turn 65, if you are already getting your Social Security benefit, you're going to be automatically enrolled in Part A and Part B. You don't have to do anything. You'll just get the card in the mail one day. Be sure to check the mail, by the way. That's a fun tip. A lot of people accidentally throw away their Medicare card because it looks like spam or junk because they're getting so much junk around Medicare time. But be sure to open your mail and make sure that you get your card. However, if you are not collecting Social Security, you will need to manually enroll in Part A and Part B if it makes sense to do that for your situation. If you are employed, and I think I'm reading a question here that I might be able to answer the latest one that came in about being on a spouse's medical plan. If you are employed, you have the option, employed, and you have a qualifying healthcare plan. What that usually looks like is a company that has 100 or more employees. So for the person that asked this question, let's make sure that and you can just ask HR, or your spouse can ask HR, are you a qualifying healthcare plan to replace Medicare? But we see this all the time. We have clients that will continue working but stay on their plan. And at whatever point they retire, then their special enrollment period occurs. And, we just want to make sure that we get this right because the dates are a little tricky. Like you have 8 months to do it for Part B and 63 days to do it for Part D. But in essence, there's never a gap of coverage. If you're retiring on August 30th, we're making sure that by July 1, you have a plan set up. Because usually you don't just wake up one day and go, all right, I'm retiring. Like you kind of, it's a little more coordinated. At least hopefully it's more coordinated than that.
John, I wanted to ask just a couple questions on this side specifically because we've been talking a little bit about the risks of missing open enrollment. Or
Yeah.
special enrollment. Is someone negatively impacted if they skip that open enrollment at 65 and enroll later on? Are there any consequences to that?
No, what would happen in this situation actually is when you turn 65, you're going to enroll in Part A, the thing that doesn't cost anything, and you'll defer Part B. And so now you'll
Okay.
have a coordination of benefits between your employer plan and your Part A insurance, and you've essentially deferred all the things that would cost you any additional dollars. You've deferred that to a later point. But the key distinction here is that you have an employer plan available to you, and it's a qualified medical plan, meaning they qualify it to replace, to work in coordination with Medicare. Usually that's 100 plus employees and things of that nature, but just ask HR that they'll know.
Yeah. Yeah. So speaking of employer plans too, if we're comparing Medicare at 65 versus somebody's company plan, how do we make that decision on what makes more sense?
That's awesome that you said that because that's the question I got is we're trying to decide if I should stay on my spouse's plan or switch to Part B or whatever I need to do. I'm 68, he is 60. This is a great example because it's like, it shows that one person can enroll, the other person definitely cannot because they're not 65 yet. My thing to answer this question is math doesn't lie. So let's do the math. Let's look at the premium cost to have you added as a spouse on the plan. How much is that costing your family per month? Let's look at the deductible, the out-of-pocket max. Let's just compare it to Medicare. That's an easy one-on-one thing that we can answer in probably 10 or 15 minutes.
Yeah. Yeah.
And then last but not least, there's one more enrollment period that matters. Well, no, sorry, there's two. There's one that matters and there's one that we don't want to do. The one that matters is, spoiler alert, the one that matters is the annual enrollment period. That's what's begun today. So October 15th to December 7th, this is our time to make changes to Medicare Advantage Part C or our Part D prescription plan. As I said before, with supplement, you could do that 365 anytime during the year, but it's specifically Part C and Part D. Now, when we make those elections, those changes, the coverage will begin on January 1st. If we do nothing, whatever the plan was that we had, and you get that annual notice of change telling you if it's going to change to a new plan or whatever. If we do nothing, you'll automatically be enrolled on whatever that plan was or what they tell you it was. But that's why it's a big deal for those Cigna folks that I mentioned a moment ago, where they're pulling out of the market in the state of Florida. There's action to take, because if you do nothing, you will not have a Part D plan come January 1st. There's also something known as the general enrollment, the general open enrollment window. This is for folks who missed their initial enrollment. It's January through March. The only problem is coverage doesn't begin until July 1. My tip is don't do this. Pretty simple slide. Like that, with enough planning, enough conversation, being proactive with us, there's no reason anyone falls into this category. So let's avoid this if we can avoid this. So, whew, well, I feel like that was a sprint in 54 minutes. We went through all the goals for the day. We've got homework for tomorrow, though. So the homework coming from this conversation is, check your tax return or chat with us. Let's make sure you don't run the risk of qualifying for IRMAA. I'm going to address a question, Rainah, that I saw somewhere in here asking, is IRMAA evaluated every year, even after you turn 65? Yes. The answer to that question is yes. And the follow-up is that it's always a 2-year look back. So for most retirees, we are having to constantly evaluate, making sure we're below these thresholds every single year, and we're not doing something that will disrupt it. And that's where, the beauty of how we all work together as advisors. We'll have Matt come in and do a tax pro forma for you, an estimator for you. And so, we like being able to do that in-house for you, where we can see your taxes and your investments and your financial plan and your distribution strategy, so that we can avoid that circumstance from happening. It's not something that you have to worry about if you're a client of ours. The second thing is, if you're not 65 yet, put reminders in your phone and your calendar 3 months before turning 65, so we don't miss that 7-month window. And then last but not least, let's audit your prescription drug plans. And for most of you that are on this, that you already know, we do this for you. Just book a time with me that's convenient. Send us over your prescriptions and we'll get it taken care of for you. Rainah, were there any more? I feel like I saw a couple more questions. Did I
Yes,
miss
there
anybody?
was one more
Okay.
that I wanted to address. You've done such a good job answering them throughout, and they've honestly popped up pretty timely, so that's great. But there's just one more. So it says, is there anything a spouse can do related to IRMAA premiums when they become widowed? So, for example, married filed jointly to single results in increased premiums.
Yeah. So if you go back to, I'm kind of scrolling through quickly. But if I go back to the slide, if you screenshot this QR code and go to that page, that's a qualifying life event. So losing a spouse, let's say, now here's the issue. So losing a spouse is a qualifying event. So yes, to answer your question, that could happen, and that could reduce your IRMAA. But if it didn't change your income, you might still be subject to IRMAA. So it kind of is situational. But in that instance, if we lost a spouse, and as a result of losing a spouse, we lost a pension, we lost their Social Security, or maybe we replaced one Social Security with the other, but there was a true loss of income to the household, then yes, very likely, and that's a qualifying event that you can send in on that SSA 44 form.
Yeah, so next steps here, in light of one QR code, we have multiple for you here
I
to
love QR
scan.
codes. My favorite thing.
Gotta have them. And so we just wanted to reiterate and say thank you so much again for being a part of this today. I know we wanted to special shout out to Joyce and Oasis. We are very thankful that you guys came. And if this was your first time joining us, or you've joined us times before, we're just glad that you're here. And if you have any questions, any more questions that came up, or if they're even just more personal in nature, you can either email John or I at John at CandorPath, or Rainah at CandorPath.com. Or again, if you pull out your phone, this QR code on the right here is actually for you to book a time with John. So if you need some time to chat through this with John, we'd love for you to book a time there. Also, as a parting gift of resource from us, please be sure to scan the middle QR code. This is a Medicare guide that lives on our website. I would keep this handy during the Medicare season, or if you'd like, you can also pass it along to somebody else if that might be a helpful tool for them. So lastly, we really want you to stay connected with us. This QR code here on the left is our Facebook page, or you can find us anywhere at CandorPath Financial. So we're super grateful that you're here, John. Thanks so much for doing that. I know you gave a lot to this presentation, and all of the updates were definitely necessary. We hope everybody has a great rest of their day, and please reach out if you need anything going forward.